Ka pai.
Kia ora.
Me te kāhui ariki whānui pai marire, me te whakaaro o ngā mate o te wā, tau koto mai, moi mai koutou, haere, 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 no mai haere mai ki te tautoko o te kaupapa o tera, te kaupapa o rangatikiri, whakaruru mō te manua. Tēnā koutou, tēnā koutou, tēnā koutou katoa. E tū. The skin for heart disease. Despite decades of public health knowledge and countless campaigns to target these poor statistics, there have been limited
commentary that reinforce that disabled people are burdens on the system. And that brings us to our intervention. A feasibility pilot study of NHI-linked disability alert system.
Yes. So with a rollout would include that as well because of the integration with the PHI medical practices, and so the patient would have to be informed that this was being performed in order to gain their consent as well to do so and add it to the NHI system, and so it would be explained there as well.
Ka pai. Going through the presentation, I was concerned that stigma was going to be a bit of a problem with your intervention. However, I quite liked your slide of challenges, and you've kind of identified some of those risks quite to primary care. Yeah, well, that's good. So the health system's working well. Quite, yes.
They have access. However, one of the main barriers that was identified as a major barrier in many cases of disabled people that worked with the specific organisation that we talked to was cost. The disability benefit is not really sufficient in order to cover the costs of GP visits for disabled people in many cases, and so definitely there are barriers there. While I can't speak to specific stats of enrolment, they're definitely lower as a result of cost.
Any more, Rosie?
Fantastic presentation, thank you, and I think you covered a lot of the different challenges and mitigations quite well, so thank you for spending time on that. One of the challenges we've got is how we define or measure disability status, and I like that you're really taking a end user approach and view on this, which is fantastic, but we also understand disability status changes over time and can change very rapidly over time. So putting it into a system can sometimes be less agile. How do you plan to accommodate the changes in disability status over time and also perceptions of that over time?
So I think I definitely agree that a digital system, as well as many things in the hospital system, not as agile as they need to be to cater to the needs specifically of disabled people. I think that again we would more bring it back to the primary care setting, who see the disabled person the most, and they are of course referred their clinic letters and various other letters from the hospital. So I think that currently we'd look at the TUI medical centres mainly handling that aspect of updating disability status by either reading updates from the hospital or from the consults themselves at the TUI medical centres.
Yeah, if I could also add to that, that's kind of where the constant evaluation comes in as well. So we are going to be using those questionnaires to
consistently follow up on our disabled patients and make sure that their status is updated accordingly.
And adding on to that, we're thinking on like the My Embassy portal, the patients themselves can have access and see what accessibility needs they have. So if they have an issue with that or if something's changed, they can go to the provider and get this changed formally.
Good question, Rosie. Thank you. I guess final comment will be just that I love the subtle comments that both groups have made so far to the current political climate and some of the challenges that we're facing within that. So, ka pai, I know the future's safe in all of your hands. I think it's lunchtime now. When are we back for the next?
1 o'clock. Is that right? Yes.
1 o'clock. Ka pai. Nice long lunch. Make sure everyone's back in and seated and ready to go by 5:02 or so. And we'll see you soon. Kia ora. Paki paki.
You managed to be fun. Thanks.
Right, yeah, fair enough. I have emailed Andrew as well. Yeah, we've got
Does he want to try connecting to the, because he just wanted to watch it himself?
Yeah.
But is it specifically, I know it's the live stream, but is it specifically both of them wanting to?
Well, I think you have eyes of steel at the end of this week.
What did you do?
Yeah,
I had that project and I said, can we use this, can we try the University of Auckland board?
Well, I mentioned it to him, I don't know which report, but he
We don't
It's just really interesting,
we also could do
I mean, living in the world where I'm help and then
yeah, okay, cool.
fresh
It's just fine here, it's just
But but anything with the teams. I really want to unplug one of the notes. Yeah, but I don't know which is the right sort of thing.
I'll go down along the cable. The other feedback from the students they can see and hear the presentation, but the questions.
Oh, okay, so we sent to repeat the questions this month. That's a really good point. Yep, no, we took it out. Yep. Sorry, that's really Yes.
Well, this is everyone from our group, yeah.
Everyone from your group's here, that's good.
Yeah.
That's good. Everyone's consulted.
I would imagine that this is, I don't know if that's everyone from the other groups. It looks like it.
2 minutes to 1, so I'm going to give them 30 seconds.
Okay, sounds good.
I'll say a quick something and then you can get going, mate.
Yeah, go ahead.
Kia ora everybody, welcome back. Hope you all had some great food for the body. Now we'll get some good food for the mind continuing. One lesson you all need to learn before you become house surgeons is punctuality. So anyone who's late coming through, that's 1 point off your whatever group they're in. So if you just let us know that. The next group is oral health. And so I'll hand over to let them go. Carry on.
Kia ora, guys. So Zach and I here will be presenting for our group for oral health. So, oral health. Compared to other conditions, especially things like rheumatic fever and the like that we've heard about before, oral health presents quite a unique challenge in that, especially with regards to dental decay, it is a very gradual process. And that sets it apart from all the other conditions. This means that unlike all the other gradual, slow processes, like global warming and the like, we are very horrible at dealing with it. It is about a healthy oral environment that suppresses dental decay at the end of the day. And this means that many things affect it, especially things that, such as environmental factors or socioeconomic environment. They have a major impact on it, and as you will see, that disadvantages a lot of our population. When left untreated, dental decay and other oral health diseases causes a significant burden on our health. This disproportionately affecting the underprivileged and the underserved members of our community. I would like to take a step back here and ask all of you guys to recall a moment when you had, I guess, teeth pain, right? When you've got pain in your teeth and dental problems, broadly speaking, it just goes on and on. And dental appointments are very expensive, which means that those of us who cannot afford it suffers. We suffer in our productivity, our ability to concentrate, our students' ability to learn, and our overall quality of life. Not to mention all the other various ENT conditions that can occur secondary to dental issues. So what's the state of oral health in New Zealand then? In New Zealand, 58% of students are caries-free at age 5. This does increase to about 68% in year 8, but overall, the prevalence of children who remains caries-free at age 5 has remained largely unchanged since 2008. So we've not made any progress in the past more than a decade. Specifically in this case, Māori and Pacific students from our research are significantly less likely to be caries-free. In comparison, at age 5, only 39% and 34% of Māori and Pacifica students are caries-free, and 59 and 64% at year 8, which is significantly lower than the 58 and 68% that we see for the general population. This inequity, as we'll soon discuss, is multifactorial, and it is a systemic issue. It involves issues caused by colonization, inequitable access to healthcare, and most importantly, the socioeconomic factors that I talked about previously, which contributes to an environment that festers dental decay, slowly and gradually, such as access to sugary foods and drinks. So dental decay ultimately is the demineralization, the slow gradual eating away of the mineral layers of our enamel and of our teeth over months and years. This demineralization is mainly dependent on the oral environment, of the pH in the mouth and the teeth. This is why we get told to brush our teeth and all the like, which cleans and resets this environment. This process, however, is not instantaneous disease, but an equilibrium between the demineralization and remineralization process, right? Things like a clean oral environment and fluoride added to water or toothpaste all represent things that supports a remineralization environment. In light of this, our research has demonstrated that sugar, firstly, is a significant determinant of oral health because it alters the pH and causes this aforementioned demineralization process that leads to dental caries, right? This means that in turn, higher consumption of sugar-sweetened beverages are associated with socioeconomic disadvantage and non-European ethnicities, Maori, Pacific, Asian, and others, which has higher availability of sugar-sweetened beverages in the home, not due to their fault, but due to the systemic overall challenges in our society, are frequently disadvantaged and have poorer oral health. We see in our research that most of disadvantaged communities have higher frequency of takeaway convenience shop visits, and the children have incorrect perception of what is a normal, adequate frequency for consumption of sugary drinks. Surveys showed that a significant portion of children are drinking sugary sweetened beverages multiple times a week, particularly in these underprivileged areas. And this means that beyond the other determinants that include low socioeconomic status, hygiene habits, and more importantly, access to dental care, just brushing your teeth is not enough. What really matters is that we try to maintain a healthy environment for remineralization for as long as possible. Effects of sugar on pH, especially prolonged with repeated exposure, is the main driver for dental decay. So the upstream intervention that we are targeting here is to hopefully eliminate/minimize these so-called sugar attacks so that everyone can spend less time in the so-called danger zone, and we can spend more time where the oral environment is healthier and promotes remineralization instead. If we return to what we were talking about previously about the inequity in Maori and Pacifica populations, this sheds light to a lot of the factors that those in the media or in the broader population overlook. Research has shown, for example, that unhealthy foods, both unhealthy store-bought food and fast food served at restaurants, are all more prevalent and more readily available, more consumed in lower decile, higher inequity, and more disadvantaged communities. This, as you see, is the primary rationale behind our campaign, the focus on the silent, sinister, slow, gradual environment that promotes and results in dental decay over time, that disproportionately disadvantages our most vulnerable communities. So what's the state of the oral health policies in New Zealand? Right? The gradual nature of dental decay means that we have to take a special approach to intervening in this problem, which Zach will explain in his part. From talking to all of our experts in the interviews over the week, we know that this isn't some new space for interventions. Many things have been tried before and have failed or have had limited success, either due to impracticalities or inefficiencies in delivery, or more likely, political opposition and the like in the community. The World Health Organization recommends low sugar intake to promote oral health. Currently, the New Zealand government has a policy under the Education and Training Act that required schools to promote healthy food and nutrition for all school students. And globally, sugar tax have been successfully implemented in countries like the United Kingdom, Mexico, and South Africa. Now, the current act actually is going to be expired on the 1st of January. Actually, it has already expired on the 1st of January in 2023. Cabinet papers have proposed replacing it with standalone regulations that would continue to promote the duty of healthy food and nutrition for all students, and optionally, this is the important part, to require all primary schools, at least, to begin with, in years 1 to 8, to support only healthy drinks, i.e. water or low sugar drinks, and have this rolled out to the entire country. So that's the current state of oral health policies in New Zealand. And this is what partly influences our campaign goals' target population. So first of all, we have decided that we are going to focus our efforts on high equity index schools in the Waikato region to maximize health equity within existing budget constraints. So first of all, reasons for this decision. Why children? That's because research has demonstrated that childhood oral health has a significant impact on later oral health in life and overall health in the entire lifetime. Why schools? Children spend a significant amount of time in schools, and as we've mentioned, tooth decay depends on maintaining an environment for as long as possible. So this, we thought, was an effective way to intervene. This is also because the government has better control over the school environment than compared to interventions or policies in the public and commercial sector, which we have seen faces significant opposition. And this, basing it our intervention in schools, makes our campaign more likely to succeed and face less resistance. We haven't restricted our campaign to specifically which part of the education, either primary, intermediate, or high school, although we imagine that our intervention would be most applied in intermediate and high schools, mostly because from our research, most primary schools are actually either of their own volition or from previous interventions, are already much better at providing only non-sugar drinks in their environment. On the point of the location, we have restricted this stage of our plan to only the Waikato region. We want to focus our efforts in taking small steps at a time and do it well each time so that we can produce demonstrable results that can prove the plan's effectiveness, which will push for its deployment, hopefully, in other regions later. And a high equity index, which is from the EQI index of 495 to 569, that in the old system would have been the decile 1 to 4 schools. We believe this is the most equitable way to implement our intervention. As you can see from the diagram there, we see that these schools are disproportionately filled with our most vulnerable people, of those with Māori and Pacifica descent as well. And we believe this is the place where our intervention is likely to have the greatest impact and therefore be the most effective in achieving our goals. So with regards to this, what are the key stakeholders in our program? Firstly, we have the key implementers. So that would be the Ministry of Education and Te Whatu Ora, right? These people would be crucial in implementing and actually rolling out our initiative. Also together with us are the principals and school leadership, the Board of Trustees. They will be the ones actually enacting the plan at the local individual schools. So these people are all people that we need this direct support from for our success. Additionally, we also have partners such as the New Zealand Dental Association and the Oral Health Association, as well as many other programs, some of them from other oral health related programs before, who have all mentioned that they will be supporting us from our interviews, and many others will need buy-in for, and many of them can provide resources that are already pre-existing, so we don't have to reinvent the wheel, that we can then use in our media campaign, as Zach will describe later, to push our message and make it even more effective. So our program obviously would, the main beneficiaries of our program would be the students and the whānau, which benefits from improved oral health, and our school staff as well, which benefits from students being more engaged and having less problems. And the main opposition that we anticipate are ones that we have already seen multiple times before in this field, which is the New Zealand Beverage Council and the Food and Grocery Council, as well as major companies that sell these sugar and sweetened drinks. Additionally, some parents and PTAs have been noted to have opposition against plans like this because they are worried about school fairs and things, and they think this may limit their freedoms in selling products at these school events. And additionally, some anti-fluoridation groups might conflate our plan as well, and they have been historically seen to oppose our plans. So these are all people that we need to carefully word our campaign around and push for the positive messaging in the community to get that drive and support behind our campaign. And I'll hand over to Zach for the next part.
So in designing our oral health strategy, we chose the Ottawa Charter and Te Paimahautonga frameworks to ensure our actions are both comprehensive and culturally responsive. The Ottawa Charter guided us to build supportive policies and environments through encouraging SSB removal from schools and supplying more water fountains, fostering community action through iwi and hapu involvement, and recruiting community champions and creating sustainable changes around drinking water in Waikato schools. This approach helps us target systemic issues like inadequate water infrastructure, in addition to individual behaviours. However, to ensure true equity and culturally meaningful outcomes, we integrated Te Pai Mahutonga, which places Māori worldview and Te Tiriti o Waitangi at the centre. By emphasising why as a taonga, strengthening Māori leadership, and supporting self-determination through asking iwi and hapu leaders what their community needs, and providing them the resources to create interventions that work within a Hawara Māori worldview. Our strategy actively empowers Māori communities to reclaim traditional water drinking practices and challenge the impacts of colonisation, such as sugary drinks. So as a part of stage 1, which is the first 6 months, we'll do the following. We're going to send out a survey to the principals of the high equity schools in the Waikato region regarding their schools' access to clean drinking water. So details of the surveys will include the method and quantity of clean drinking water supply that these schools have, whether the children utilise the water supply effectively on a scale of 1 to 5, and are they currently a water-only school? And if not, what are the reasons for that? We will also get the students in these schools to uptake an initial survey on their SSB consumption, which inquires about their attitudes towards SSBs as well as their water consumption. We'll work to build a coalition with identified stakeholders, including iwi, education, and health organisations, as previously mentioned. And following this, we will co-design culturally responsive policy toolkits with allied partners that include iwi and hapu leaders and church ministers that emphasises why as a taonga and addressing sugary drinks as an impact of colonisation. The principle of sugar is not our whakapapa, pushing less emphasis on health education and pushing healthier lifestyles onto people that they already know about, and more onto a Hawara Māori worldview. This aligns with the Ottawa Charter's policy focus and Te Pai Mahutonga principles. So stage 2, we want to upgrade water infrastructure in schools, specifically thinking about fountains and reusable bottles, but also guiding schools on the ways in which they can contact the Ministry of Education to get their funding for self-supplied water, which exists but many schools don't know about. This will all be guided by iwi consultation and cultural designs, as previously mentioned. With the upgraded water infrastructure in place, these schools will then be supported to introduce a water-only policy. As part of this, we will facilitate community-led hui with organisations who are pushing back to overcome these barriers, as supported by our liaison officer. This reflects the Ottawa Charter's supportive environments and community action, as well as Te Pai Mahutonga's Toi Ora and Ngā Manakura. And then finally, in stage 3, so as you can see from the timeline, this is largely an evaluation and monitoring stage, which I'll come to in just a couple of slides. But to summarise, we will aim to expand our campaign to be nationwide and endeavour to push the government into mandating all schools to having a water-only policy. Together, these stages ensure our campaign sustainably improves oral health, honours Te Tiriti o Waitangi, and empowers our Māori communities. On this slide is a pie chart surrounding our budget. So, as you can see, this is how we would spend the full $1 million over the first year of implementing our campaign. The bulk of the cost is taken up in salarying our employees and installing water fountains in schools, as well as supplying students with reusable water bottles as a part of this scheme. So this $250,000 for water supply will allow us to install 100 filtered drinking fountains, as well as supply students with 10,000 drink bottles across all of these schools. The remaining budget will be spent on iwi grants, recruiting community champions, and fountain maintenance alongside conducting surveys and any extra costs. Now on to evaluation, which I briefly touched on before, and this is a crucial factor in ensuring the success of our campaign and that we reach our ultimate goal. 12 months after the start of the campaign, we'll conduct an identical follow-up SSB consumption survey for all students in the schools where we implement an intervention. Assuming that this then shows a reduction, we will apply for further funding to expand our intervention on the basis of these results. In this, we will also enroll these students into a long-term, longitudinal cohort study, where we will follow up on their oral health outcomes and compare it to the age-matched population oral health data. Then 36 months into the total campaign, we will follow up on the cohort of students included into this study and reevaluate their oral health outcomes. If this evaluation shows a relative reduction in their negative oral health outcomes compared to an adjusted set of population data with matching demographic status, then we can deem the program to be an overall success and petition the government, alongside our coalition partners, for a complete ban on SSBs in schools on the basis of strong epidemiological evidence that would improve youth oral health outcomes. Now onto the expected impact. So, as we're running a bit short on time, improved understanding of current barriers and why SSB consumption is as high as it is. There'll be improved water infrastructure, and finally, there'll be engagement and collaboration in the community. And then as for long-term impacts, we hope to see a sustained reduction in sugary drink consumption, a reduction in dental caries, and system-wide policy change. We know that governments have tried and failed in this before, but we hope that by providing them with irrefutable evidence and by uniting a range of stakeholders across Aotearoa, that the appetite for policy change will emerge despite a backdrop of corporate greed and political cowardice. And now, just something to leave you all with. He pai te inu waiora. Water is life. Drink it. Thank you.
Kia ora team, sorry to push you there, but as well as punctuality, timeliness is a very important skill, so ran a little bit over schedule there. Any questions from the esteemed audience? Nope. I was wondering what you felt that, look, schools have obviously been feeding back about sugar-sweetened beverages, more importantly energy drinks, as being a major disruptor in schools for a long time. But you focus very much on sugar-sweetened beverages and not the fact that carbonated drinks are not particularly good for the teeth either. Is there a reason why you separated them out?
So, oh no, Tom, you go.
So the current water-only policies would mandate just water and milk consumption in schools. So they would actually cut out a lot of the other carbonated drink consumption in the schools as well. So that would address that issue. So we'd be broadening the access to that. Yeah.
Good point. Yeah.
Thanks. Great presentation, thank you. I just wanted to ask, I don't know, I may have missed it. Is this a voluntary, like you would be encouraging the schools in a voluntary way to participate in this policy?
Yeah, so we've hired a lead. Well, our plan involves hiring a liaison officer whose specific job is to basically act as an intermediary between schools and the other stakeholders, and then that will allow schools to basically, hopefully, adopt this policy. It would be voluntary initially, but our final ultimate goal is to build up a pool of evidence that will hopefully be able to push the government into mandating that all schools have a water-only policy.
I think since we're probably running over, we should probably call it quits there. So, paki and welcome to the next.
Ah, there it is. Awesome. Kia ora tātou katoa, ko Bradley toku ingoa.
Kia ora whānau, ko Jamal toku ingoa, and thank you for coming to listen to our presentation today on food and waterborne illnesses. We're going to be focusing on Campylobacter, so Bradley, take it away.
Cheers, Jamal. As Kiwis, we love chicken.
whether that's smashing a box of KFC or chucking some drummies in the barbie. But for many Kiwis, little know about the significant health risk from our consumption and handling of poultry products. Campylobacteriosis is a notifiable disease in New Zealand, meaning health professionals and laboratories are legally required to report confirmed cases to public health authorities. It is caused by an infection with Campylobacter bacteria, most commonly Campylobacter jejuni. This illness has the highest notification rate of all foodborne disease in Aotearoa. In 2023 alone, over 6,000 cases were reported, making it a leading cause of bacterial gastroenteritis. Campylobacter bacteria are primarily carried through the intestinal tracts of animals, especially poultry, cattle, and sheep. These animals serve as a reservoir, often without showing symptoms. Humans typically become infected through the consumption of undercooked chicken, unpasteurized milk, or contaminated water. Cross-contamination during food preparation is a significant risk factor. When we break down the reservoir, it has been estimated by experts that 75% of campylobacteriosis incidence is due to foodborne transmission. It was further estimated that approximately 75% of foodborne campylobacteriosis was due to transmission via poultry products. The burden of disease is substantial, not only in terms of public health, but also economically. In 2010, the estimated cost of illness for campylobacteriosis in New Zealand was $134 million, including direct healthcare costs, loss of productivity, and long-term complications such as Guillain-Barré syndrome and reactive arthritis. So what's been done and who are the key players? Currently in Aotearoa, food safety law is governed by the Food Standards Australia and New Zealand. They are responsible for developing joint food standards across both New Zealand and Australia and implement this into law for both countries. New Zealand Food Safety are a unit within the Ministry of Primary Industry and oversees the implementation in Aotearoa. New Zealand Food Safety are the key advocates for reducing campylobacteriosis rates. They have halved foodborne campylobacteriosis levels since 2006 and have achieved this through controls on poultry manufacturers. Examples of such are immersion chilling, decontaminated washers, and implementing a Campylobacter performance target within the poultry sector. They've also been influential in publishing new international guidelines on best hygienic practices in poultry handling and subsequently enforcing. More recently, New Zealand Food Safety have created a goal between 2020 and 2024 to reduce Campylobacter foodborne transmission by 20%. They have initiated this through creating co-governance between key regulatory bodies and stakeholders. They have indicated this, they have done more research into food safety messaging and recipes and customer behaviours who interact with the MPI website. And within this space, we think they can do more for consumers. So our rationale for our campaign is that while strong industry regulation exists, their current framework lacks mandatory requirement from Food Safety Australia and New Zealand for including food handling instructions on poultry packaging, resulting in inconsistent labelling, particularly for chicken prepared and packaged in supermarkets. Epidemiological evidence highlights these knowledge gaps in our society. A 2018 study by Michael Baker found that 55% of participants knew they shouldn't rinse their chicken to help reduce Campylobacter rates, meaning that a large percentage of our population still believe that rinsing chicken is considered safe handling. 70% of respondents felt that correct handling and cooking information on labels was essential. More recently, in 2024, the New Zealand Food Safety Consumer Food Safety Insight Survey found that 79% of consumers either believed raw chicken should be washed or are unsure. Despite the risk associated with improper handling of poultry, the last research engaging with our Māori communities and their perspectives on the issue was actually in 2008, highlighting the need to centre Māori voices in any policy development. Our campaign proposes a policy change to introduce a mandatory minimum standard label on raw poultry products in Aotearoa, aimed at addressing critical consumer knowledge gaps around food and safety. Our campaign pushes for this labelling policy reform as a practical, population-level tool to reduce foodborne illness and promote health equity through clear, accessible guidance at the point of purchase. When considering our framework of the Ottawa Charter, we navigate through building healthy public policy and developing personal skills, which are all aligned with the NZFS action plan.
Thank you, Bradley. So how are we going to actually achieve our campaign and roll out our campaign? Well, we've got 4 key specific objectives that we want to fit, and we want to roll out our campaign in a stepwise manner. So when we look at our first objective, phase 1 of our campaign, we really want to form a local advocacy group with local council, local Waikato Tainui iwi leaders, and public officers of health, experts within the region. As the campaign gains traction, we want to move this to a national level and expand our advocacy group. We then want to move into phase 2 of our research. Again, what's the most important thing here? It's he tangata, he tangata, he tangata, it's the people. So we want to look at what consumers really want and need, focusing on them through our research, utilising research institutions like the University of Auckland, Waikato University in our local region, and lots of different kaupapa Māori providers. We want to make sure that we have Māori inclusive research. As Bradley's highlighted, Māori voice is clearly lacking in this public health issue at the moment, and so we need to establish Māori voice. When we're doing nationwide rollouts, involving organisations like Te Pūnai Kokiri, the Māori Ministry on Wellbeing and Development for Māori, would be critical, imperative. So moving on to phase 3, this is all about creating partnership. And to do so, we're going to align our advocacy group with the existing New Zealand Food Safety Campylobacter Action Plan governance group. We want to align values between our advocacy group and this governance group to form a common agenda so that we can achieve our ultimate upstream goal, which is submitting a proposal to change the FSANZ code within New Zealand and mandate advisory statements on fresh poultry labels based on research. Who are our potential allies here? Well, at a local level, we're looking at organisations such as the Waikato District Council, the Waikato Council itself, iwi groups, and public health experts. As we expand nationally, we'd like to include research institutions like the University of Auckland. In terms of our potential opposition, we know that we have a duopoly of food providers within New Zealand, which are Foodstuffs and Woolworths, and we think that they would be opposed, potentially, to this campaign as they want to maximise their profits. What's our target group? Again, just to re-emphasize, we're looking at the existing group and merging our advocacy group with this existing group. This is the New Zealand Food Safety Campylobacter Action Plan Governance Group. And they consist of all these different bodies, such as New Zealand Food Safety, which is under the Ministry for Primary Industries, the Poultry Industry of Australia and New Zealand, the Commerce Commission, Foodstuffs and Woolworths, the Ministry of Health and Consumers. What are our campaign messages? Here we really thought it was important that we kept coming back to 3 core messages and created a cycle approach, so that while we were rolling out our upstream policy changes, all the way down to our downstream approaches at the consumer level, we kept coming back to these core messages. These were inclusivity, and at the moment that involves creating Māori voice and establishing Māori voice within this area. Later on, as research expands, we could look at getting into accommodating for rural voice as well, and our other marginalised communities. Moving on, we're looking at aligning values and goals, creating partnerships. This is between our advocacy group, the groups that actually make up this advocacy group, like I've alluded to, with the council and our research institutions, and between the New Zealand Food Safety Group as well. So we're just all about creating partnerships here to finally create our ultimate upstream goal, which is creating the policy change, making it mandatory that we have labels on poultry. What are our timeline of actions? In the short term, over the next 6 months for the rest of this year, we want to create this advocacy group with our allies at the local level and expand that to a national level as research and the advocacy group gains traction. We want to conduct our research at the local level and create that strong foundation of evidence so that we can expand nationally and focus on establishing the Māori voice. So that as we move into 2026, we can collate evidence at the national level and pitch to New Zealand Food Safety to form that alliance, creating a partnership with a common agenda. In the long term, our ultimate goal is submitting the proposal to FSANZ to mandate advisory statement labelling, again creating that upstream change at a policy level. In terms of monitoring and evaluation of our campaign, there's 3 core areas that we want to focus on. Firstly, Qualitative measures. Are we making sure we're actually targeting the people and getting their opinions on what needs to change? So we'd be performing surveys outside supermarkets, at local events, and using polling organisations. Assessing the visibility of our campaign, the actual ideas of the public, what do they want on our labels? Is there clarity around our labels? And have the labels actually affected their practices? Because we know that we need to change practices in the long term to improve our rates of Campylobacteriosis in New Zealand. And at a quantitative level, we need to look at monitoring public data on notification rates and hospitalisation rates and making sure that we continue to improve accessibility for Māori to actually be able to notify Campylobacteriosis, as we know that accessing health services is a current area that we struggle in Aotearoa and that has inequities. Finally, the analysis. So we want to identify the trends over time through our research by looking at the public perceptions and behaviours, our reported cases versus our hospitalisations, making sure we have an equitable impact on this, and looking at any barriers to successful implementation that come up through our campaign. Our budget of $1 million. We thought that the key core value within our campaign is partnership. And so partnership and lobbying receives the most funding here. That's partnership between our allies, partnership between our advocacy group and the New Zealand Food Safety Governance Group, and it's lobbying to FSANS. That's where we think the most amount of money will need to be dedicated towards, 40% of our budget. In terms of our research, we think this is going to require about $300,000 as we expand from a local to national level. We also think that media and design will require a decent amount of money at $100,000, and that's implementing things like labels and trialing different designs. Finally, we want to have a project manager who kind of oversees and leads our advocacy group to propose towards FSANS at the end level, and we think this will require $75,000. And then meetings and travel and unforeseen costs will take up the rest of the budget. What's the expected impact of all of this? Well, we've divided it into short, medium, and long term yet again. In the short term, it's ultimately that we form a larger evidence base, as we currently still lack epidemiological evidence within this area, particularly around Māori voice. We want to make sure that it's consumer-informed decisions that arise through our campaign. In the medium term, we need to ensure that we can actually make change at an upstream level to ensure this is a long-term successful campaign. So we want to submit to change policy through FSANS. And finally, in the long term, our ultimate goal is lowering rates of Campylobacteriosis in Aotearoa. We've designed some example labels based on the 2008 study that engaged with Māori focus groups and Pakeha focus groups. Again, it would be great if we had some more up-to-date ideas around what specifically like Māori want with labels and what our New Zealand Europeans want with our labels. But what did come back was that people wanted clear, easy to read labels, they wanted big visuals, and they wanted them in orange, because orange was a colour that told them to slow down, like at the traffic lights, and actually read the information and take it all in. So here's two labels, but I'm sure we could do a hell of a lot better as we develop our campaign. So kia ora everyone, thank you so much. Yeah.
Well done, guys. I was a little disturbed there if I go back one. I thought that first label looked like it said, wash your hands but don't rinse them afterwards. So I was glad that wasn't that. I love the idea of some mandating industry. I've always thought that self-regulation relates to regulation in the same way as self-importance relates to actual importance. But I was just wondering if you could expand on how you think that you're going to get any kind of regulatory measures through in the current political climate of liberalisation?
That's a great question. Players in the region, so yeah.
Oh, we've got a contribution from the screen as well.
I think obviously it's a very tricky question, but I think ultimately, I think the country is very liberal, but if this, the whole point of the evidence and the partnership is ensuring that this is actually what people want. And while we do live in a very liberal place, and obviously mandating has kind of gotten a bad rep from COVID and everything, if this is something that the data shows that people are actually wanting because they're not sure about, they're not clear about, like people always want more information and more transparency information, then I think that actually kind of aligns with like the reason why things are liberal in the first place. Like, and whether we're mandating or wanting to be more liberal, it's about kind of more like making sure it fits with what people want, and that information is transparent and people are informed.
Okay, next question is, unless there's any questions from the floor? Rosie's got one. Sarah?
Yeah, thanks team. I was wondering, I'm assuming that most of the chicken purchased in Aotearoa comes through that supermarket duopoly, that there's not a lot of chicken that is either reared at home / through butchers' shops, things like that.
Yep.
In which case I was wondering around the Māori equity side of things, because I'm a dietitian by trade, and from what I understand our Māori communities tend to have the same shopping habits as non-Māori, so why would there be a distinction, I guess, between really honing in on our Māori voice?
I think where previous interventions have happened, just in general health policy, is that they tend to marginalise Māori groups by not allowing them to have a voice and a seat at the table when implementing new interventions. So we understand that what Māori practices, well, we actually don't necessarily know a lot about Māori practices now, but what we're trying to do is allow them to also be vocalised in our research so that we do understand what they're doing, and when we implement something, that we're not just leaving them to the side like our previous interventions have done in previous health policy. So we want them to be on the table so we can get insight on how we get into those groups and get good quality research that we can propose.
Thank you. Thank you for a great presentation, really interesting, and I like the examples, thank you. Your monitoring and evaluation plan was fantastic in terms of looking at some different perspectives and measures. Obviously, if this went through, it would involve companies actually coming to the party. I didn't see them mentioned in the monitoring and evaluation, and is there any consideration on the value of measuring impact or other metrics within that kind of end user group as well?
So do you mean with the supermarkets themselves coming on board?
Well, no, actually the chicken companies that actually produce the chicken, or like, because you mentioned frozen chicken products and things like that, they'd already be packaged before they got to a supermarket. Yeah. So I imagine that there might be a role to play for them in terms of having labelling on their packaging.
Awesome. So there's lots of aspects to your question that we had a lot of focus on over the week. So what we found out, and kind of what Bradley mentioned, is that there already is like strong industry buy-in. So NZ Food Safety have put very strict measures in place with the poultry industry, and they're continually improving like things like cleaning and various other scientific techniques to make sure that Campylobacter rates are really, really low. So what we kept finding out through the week was that Campylobacter rates was it way less than 1% in chickens that actually come out of the industry. It's just the amount of chicken that we have in New Zealand we consume. That means the rates are actually higher. And I guess the second part of your question, we were debating a lot whether we do voluntary engagement through supermarkets or whether we mandate it. And we think for any change to actually happen, you have to mandate it. And I guess there's a potential flaw there. Our supermarket's going to be happy about the fact that it's mandated, or is it just something that has to be sucked up and done for the greater good of the public?
Oh, great. But just thinking about the actual measures of impact, would there be any impacts on those, I don't want to say chicken producers because they're not, I don't know what the right terms are, I don't work in food safety, but yeah, the actual companies that produce the chicken, would there be any impact on them, do you think?
So after talking to the poultry pioneers, they actually were quite for labelling, but the only problem with, there was a previous petition for like labelling in the past. The problem with that was that they did not enjoy that the fact that labels were warning signs. So we were very focused on having our labels having more of a holistic message and more education rather than this chicken is infected with Campylobacter. So it would be, but they were more than happy to have labels. They also have labels themselves. So the supermarkets are independent of this. That's why we chose mandating would have to be the proper way to go.
Thank
you. As long as we don't incriminate their products.
Yeah. Thank you.
I don't know if we've got time left. I was going to ask, first of all, we know that data is pretty poor on notifications. There's been a wide variety and anticipated up to 220 cases of of gastro for every case that's actually notified. And secondly to that, you've already mentioned the inequity potentially within notifications. But there's actually also some quite severe restrictions on who even gets tested, even when they do have gastro, and do present to the primary care if they can get an appointment. All of those factors in, how do you think you're going to actually measure any success of this intervention, considering you're mandating an improved self-responsibility rather than an intervention which is actually decreasing risk to the public?
I guess there's always going to be an inherent flaw in the research, but we hope by targeting a very upstream cause that it still will have an effect. But I guess in our discussions we need to be clear that there are those issues, and we don't have enough money to solve everything. We can't increase with our intervention isn't targeting more testing, and except we're trying to prevent people from having to test. But yeah, that probably doesn't answer your question. But
I don't think you could have, to be honest. That's why I posed it. Top iron trying. Okay. Thank you for the group. And final group is death and dying. Go on down.
Hello everyone, so final group of the day. So we're presenting on death and dying. Before we start, I think I'd like to begin with a bit of a story that's not uncommon from something that happens quite often in Aotearoa every day. Imagine that you have a family member who unfortunately over the last couple of months was diagnosed with an end-stage cancer that's metastasized throughout their entire body. They've gone to hospital, and the decision that's been made in hospital is that they are no longer for treatment and they are going to be put on an end-of-life care plan. Most people in New Zealand, and the vast majority of people now, will be dying at home as opposed to dying in a facility. And the plan that was made at hospital was that they would return home to be with their whānau and hopefully die there surrounded by friends and family. Unfortunately, this family member lives quite rurally and about 2 hours from the closest emergency department. And so a huge plan is put together by the hospital with an advanced care plan written up, a set of specialist care plans with special medications that can be given if the patient has an emergency, and an advanced directive and a do not resuscitate order is made. These are all sent off with the patient, and then you, the family, are there with them over the next couple of weeks. Unfortunately, on the first night, you notice that things are much rockier than you anticipated, and your family member seems like they're in a lot of pain. But unfortunately, being on a syringe driver and being on medications already, they're not exactly as vocal as they used to be and aren't able to clarify things that they want around their care. Not knowing what to do, you call the ambulance. And the ambulance arrives and they look through your patient's documentation, your family member's documentation, and they decided the best thing for their patient is to treat them using the emergency medications that are provided from the hospital. A mechanism that they would not have otherwise if that piece of paper wasn't found. And they're able to read through the advanced care plan and decide not to transport because it was against this patient's wishes. This is an example of everything kind of going to working in unison and working as intended, where somebody is able to express their autonomy and then die in a manner that they see fit. For many in Aotearoa, they will want to die at home surrounded by whānau and friends. But this is a very difficult process that requires a lot of synchronous work from a whole heap of different groups and services throughout the country, not limited to things like paramedics, GPs, palliative care services and hospice. Often, patients nearing the end of their life are not able to express their wishes, and their autonomy is limited by this, and we have made several documents to try and increase the amount of autonomy patients have in these final hours. This includes things like advanced care plans, where they can write informal requests about what they would like in a less legislative manner. An advanced directive, which is a legal mechanism where they can stop, where they can opt out of certain procedures like resuscitation, intubation, or ICU care. And another document that often follows these patients around is a patient care plan, which is a specialist like standing order that allows for anyone in the community to give a medication that would normally not be within their scope. These documents form a critical role for those at home, but there's often issues surrounding finding them and using them and activating them. There's several shortcomings, and the largest shortcoming is that these are all paper documents that place the burden of responsibility onto the family members of the person who is going through the dying journey to present them at the time when they're needed, to make sure they're always on hand and to carry them around constantly. There's very poor uptake of some of the usage of these documentations. Only 4% of older New Zealanders have an advanced care plan in New Zealand. Legal documentation cannot be used under any circumstances unless it is witnessed as a signed copy. So an advanced directive or do not resuscitate order can't be used unless it's witnessed by, say, a paramedic in the community. And these are obviously quite difficult to find in the heat of the moment, especially when the emotions are high and things are difficult. This leads to a set of adverse outcomes for patients. Certain cultural wishes may not be honoured. Patients might have specialist requests, especially if they're in ethnic minority groups throughout New Zealand. Maori and Pacifica groups might have specific wishes around their dying process that they want to be honoured instead of the westernised system that we kind of default to for everyone. Patients might be transported to the emergency department for symptom management that they don't require, and patients in some extreme circumstances might die in those hospitals, especially if they're rural and they live at a great distance from one of them. And then very occasionally in New Zealand we have inappropriate resuscitation of a palliative patient because a do not resuscitate order wasn't able to be produced at the time of death. We propose that several of these issues could be solved through the creation of a national database to collate these documents in a searchable manner that everyone involved in the patient's care can access. Creating such a database would be incredibly sophisticated and would require a lot of buy-in from different groups around the community, as well as an implementation strategy. Instead of campaigning to create a database, we are campaigning for the creation of the Kāmata Working Group, which is a group of researchers who are going to generate a report around the feasibility and implementation and need for an advanced end-of-life care documents database. They will examine the current landscape and make research surrounding the current state of end-of-life care in New Zealand and the use of these documents, and determine the best method for implementation of this database. They will consult with many key groups around New Zealand to make sure that this database is culturally appropriate, and that if we modify things like the advanced care forms, that we can make those also culturally appropriate. And assess cost and other key factors that we are not aware of at this point, finalising a report that can be published with recommendations for changing policy. We have aligned this group with the Ottawa Charter, so we believe that they should be able to strengthen community action through consultation, enable, mediate and advocate for patients who don't have autonomy to do that at this point, create supportive environments for patients who are in reasonably dire circumstances and who are quite vulnerable, and reorient health services and give them power to do what's best for their patients.
So our working group is going to work with these target groups and they're going to consult them. So this is not an exhaustive list, but it includes iwis and Pacific leaders, religious and disability groups, and by consumers we mean people that are going through the process of death and dying, their friends and family as well, a lot of healthcare personnel as well as legal and ethical entities, and as well as that we've identified some affected physicians that might want to get involved, like palliative care doctors, rural and urban GPs, geriatricians and pediatricians as well. So why would we be doing this? Well, we want a culturally safe response, which encompasses a non-Western, non-mainstream understanding of death. And we also want to take into account an equitable lens, and often minority and marginalized groups are left out of discussions, which leads them to be less likely to be engaged or tap into resources that are available. And further, we want to identify concerns like data privacy or accessibility that might arise from these discussions. Further, we want to gather ideas from relevant groups and experts to see their unique lens on death and dying. So the consultation groups, we've broken them down. So first, we're going to be looking at design. We want it centralized and potentially integrate it with current resources that are in place, like My Health Records. We want an interface that's clear and accessible to all. Also, we want to think about questions like who is going to contribute to this database, who has access to this. Further, we want privacy mechanisms in place. Is it consent-based? Who can access encryption and more of the logistics of that? And secondly, the content of this database. So we want healthcare needs as well as patient needs both to be balanced and a part of this. And we understand the ACP is there, and we would like to have potential adjustments to include more information like health-specific needs, healthcare-specific needs like the resus status, the ICU needs, and more specifics into it, which the ACP planner doesn't have. Further, we want patient input, more about their goals, their values, what their family and friends want as well. Further, we understand the group will be working on a project which requires legislative change. Without it, it's just not possible. So we want a legislative change to support the rollout of the project, potentially something like what age do you propose this for patients, and also is it going to be an opt-out system or a compulsory model? There's just some questions that will come up. And then furthermore, working group will work on determining the barriers of implementation of our database. So first up, cost, the upfront setup, training, maintenance. We want to know all of that. And then secondly, this is an online database, and there's potential professional entities that are going to be involved as well. And we understand equity is an issue that's going to arise. There's the digital divide as well as professional access that's not just available to everyone. So we want to see these goals and potentially work on them as well. Further, we want coordination. We want to build systems between current resources in place and organizations to build a more integrated system. And then we want to build a rationale for a nationwide implementation, which is going to include cost effectiveness, interregional communication, feasible means in which equity issues can arise and we can tackle them, and further value for the individual themselves. Also, we don't want to just focus this on ACPs. We want breadth of documentation, so we want additional plans like EPOAs, DNRs, advanced directives, specialist care plans, as well as funeral plans that can also be a part of this.
So we have 3 phases to our strategy. The initial phase is a consultation phase where the working group would consult with the people that Dill's already spoken about, so those different cultural groups, iwi groups, also I guess healthcare professional groups, amongst others. After that comes the collation phase. The initial part of the collation phase would be to, I guess, get a thematic analysis of the qualitative data that we gain in that consultation phase. Then secondly, auditing that data to look at what sort of gaps exist, what groups maybe did we not tap into, or what information were we not able to extract from those groups. And then finally, potentially a reconsultation phase within that collation phase to gain that information that we identify within the audit is necessary. The final phase is synthesis, so this would be putting all that information together, putting it into a report, and then publishing that report publicly so that that information is able to get out there. In terms of evaluation, I guess there's 2 parts to it. Firstly, there's the external evaluation, which is auditing, both in terms of auditing like the finances and the schedule to ensure accountability, but additionally auditing the actual data that we gain as part of that collation phase that I've just mentioned. And then finally, there's also an internal self-assessment and evaluation that could look like quarterly reporting or meetings to identify gaps and things like that. In terms of our budget plan, the large majority of our budget will go towards the core personnel for this group, and that's because we want to have a small full-time team that involves a project manager, a population health expert, and multiple researchers who are going to, have this as their main focus over time. But additionally, we want to tap into part-time or contracted groups such as a bioethicist, a kaupapa Māori expert, who would be able to help us on a limited time basis do that. And obviously that's quite expensive. The median wage of a lot of these people is over 100K, which is why that's the we've used the median wage to decide that's how much we need to spend in our budget. Secondly, on community and stakeholder engagement. So when we talk to these, when we liaise with these target groups, we know that we want to give them koha for their time and expertise. We know that we want to ensure there are interpreters there, ensure that there's appropriate places to be able to hold these discussions, and as such we've dedicated a portion of our budget to ensuring we're able to do that. And finally, on legal framework, obviously this will interface with a lot of laws, the Health Act, Privacy Act, HDC, there's consent framework to consider, and so we know that we'll need to hire lawyers even on a short-term basis to help analyse a lot of these things and also ensure that we are working within an ethical framework. In terms of the impact of the report, the reason that we think it's likely that this report will be considered by government or Te Whatu Order is fourfold. Firstly, when the publishing of this report is likely to generate some sort of media impact that will bring awareness to the public and therefore put public pressure potentially onto the government to implement some of these changes. Secondly, within the report we may be able to identify cost-saving areas that may actually be helpful for the government and therefore they may have an incentive to implement it there. Thirdly, we are obviously choosing to liaise with a large number of groups. Those groups, we hope that will be able to accurately reflect their goals, their aims, and what they want in the report. And therefore, they would have an incentive as well to want to have that report put into place, want to pressure the government. That could even lead to active lobbying potentially. And finally, we're giving them some free recommendations, I guess, that they haven't had to pay for. So hopefully they'll be grateful for that and want to implement some of it. So the impact if that end-of-life care document database is implemented, firstly, we gain a huge benefit in terms of patient autonomy. Like the story Ben told you at the start, people have many, many different ideas about how they want to die. And as we need to ensure that that those ideas are actually respected. That doesn't happen in the status quo when you can't find the document or you didn't know the document existed. Secondly, cultural appropriateness, because we know different cultures have different preferences and ideas that the ambulance staff entering your home may have no idea about. And thirdly, guidance for first responders and other healthcare professionals. They now know where to access this information. They don't have to go searching through your home at 3 a.m. in the morning to try and find it. Finally, we looked at many studies which tell us that an increased use of end-of-life care databases or having these formalised online actually means that people are more likely to do an advanced care plan themselves because they believe it will actually be respected, and therefore they've got to invest the time and effort into writing that down when they know that people will actually care about these. Finally, even if it's not implemented, we can still publish these findings, make them publicly accessible, and communicate the desires of these disenfranchised groups, identify the barriers and communicate those as well, and collate important statistics. So even if the government chooses not to take this up, we still think that there's an immense value in this process in unlocking those voices that have previously not been reported on historically. That's our presentation. Thank you.
Thank you, team. I always feel sorry for everyone who isn't a presenter and has to just stand up there in the spotlight and try not to pick your nose, but well done. There seems to be a bit of a theme, I suppose, of more systems being designed to solve problems, when in reality all we really want is one database to rule them all. But the UK tried that and failed pretty spectacularly, so I'm not hopeful that will happen here. What do you think the potential risks are if you have such a database up and running and somebody changes their mind?
Yeah, so I guess there's a continuum of what this database might look like. On one end, it might be users can go on at any given time and change their wishes and change what they want about the advanced care plan immediately up to date because of the internet. On the other hand, it could be gate-kept by health professionals. You have to go in and see a GP. You have to have that formally uploaded by an official healthcare professional or things like that. And obviously within 1 week, we weren't able to figure out what the majority of the population would prefer, what minority groups would prefer, or things like that. So we hope that a working group would, within that continuum, hopefully be able to place on it what people actually want, because we know on one end of the spectrum there's privacy issues if anyone can just go online and change things. There's issues around, has a family member written that you don't want to be resuscitated and you actually do because I've got your login. But then on the other hand, there's obviously the access issues to having to go to a GP if you're a rural person or if you don't have a lot of money. So I guess we're hoping somewhere in between those two things would get discovered by this working group as the ultimate goal.
Good answer. There's the third problem of cognitive ability that also declines, and the question as to whether a decision made some time ago is still relevant if they don't have the ability to understand the repercussions of it now, and that's certainly part of the problems with the end of life care bill, or not problems, but it's a hurdle there. Any questions from the floor? Hooray! Yes!
Not really a question, but just like excellent presentation on an area that's not really talked about that often in New Zealand, but death and dying. We have a pretty poor culture around death and dying here, I believe, so great presentation on it.
Kapa. Rosie.
Thank you, and I echo that great presentation, and I think starting with a story was a fantastic way to introduce it. This is a problem we have across the healthcare system in terms of access to information at critical times. Did you reflect on successes or failures of similar types of systems in other areas in your consideration and of your proposal?
Yeah, so when we, I guess, were first floating this after speaking to the topic experts and the industry groups and things like that, it was actually interesting to see that around the world lots of these systems do exist, so they're quite common in, like, just within states in the United States. Singapore has one, and even within New Zealand, Auckland is piloting a program very similar to this, where they're able to collate all of that palliative care data as well. And so it was really interesting, I guess, reading a lot of the reflections that they had about it was that this, in terms of the benefits, significantly increased the uptake of people actually investing in advanced care plans where they otherwise wouldn't see a benefit. In terms of some of the drawbacks, particularly for New Zealand in the Northland study, we know that body groups had, I guess, concerns about some of their data being collated in this way, and I guess like privacy concerns and things like that. And even speaking with our population health coordinator, Leanne, we know that Māori people are some of the most studied people in the world for what benefit at this stage. Like, we've got all these studies that exist and not a lot of benefits for actual Māori people. So those, I guess, are some of the barriers that we would be considering. How can we communicate their wishes, ensure we have a culturally responsive, like end-of-life opportunity for those people without having to parade all of their, information and research them further and those sorts of things. So hopefully we'd be able to discuss with those groups to figure something out there, but we know that that is an issue that we currently haven't been able to overcome.
Yeah, no, fantastic. And so thinking about, and it was great that you've seen some examples of where elements of this are being done. Is there opportunity to think about, the ideal is something that's incredibly interactive, I suppose, in terms of people being able to update, or agile might be a better term, and accessible on a number of different platforms and within the community. Is there a sort of a second tier kind of option here where you might think about starting small and working up to that ideal? Welcome the rest of the team as well.
We nominated a question person, which is why I'm answering.
Okay,
We've discussed most of these questions already. So a lot of these other programs centre solely around advanced care plans, which are non-legal, non-binding, in combination with their own clinical judgment to decide what to do. And so that might be step number one, given that it's non-legally binding. You don't have to say, oh, because it says this, we can't take this patient to the hospital, we have to leave them to die, possibly a painful death at home or something like that. But you still get the benefit of actually being able to say, if I don't have a voice because I'm unconscious, I want this to happen. Or if my family members aren't around, if I've had to travel outside of my normal hospital network and you don't have my patient notes or things like that, please know that I'm Buddhist and I would like this, this and this.
Yeah, fantastic.
Any more questions? Very well answered. Okay, paki for the last group. Yeah. Okay, was asked to ask you something, but I'm going to talk because it's my prerogative and I've got the mic. Really great presentations from all of you today. I think that's the easy conclusion, since there was no questions from most of the students, that they must have been very comprehensive and well covered in each topic. So that's great. These topics, they're not easy. They're not meant to be. If they were easy, we might have fixed them already. But wicked problems often need kind of complex and multifactorial solutions put through to them. I really enjoyed all of the presentations today, and your abilities to consider the equity implications, which is one of the key foundations of my mahi, as well as being able to take a step back and look at some of the underlying drivers to be in the situation where we are. I'd encourage you to keep thinking bigger picture throughout the rest of your training, and as you go on through your training and into your specialties, you're not going to be able to look back and say, oh, we never saw this coming, because you've all been well warned as to where we are and some of the problems that we have in society. The final thing I've got to mention is evaluation. I believe you've all got forms that need to be completed. Leanne, is that correct?
There should be links to them on Canvas, I think, for the evaluation. So now's the time to do it, because we've got a little bit of a break before we go up for the wrap-up. So encouraging while the assessors are conferring on the winner of this, out of the Waikato presentation, that you take that time, because if there were things, and I know there were things that my group picked on about, for example, around the use of PowerPoint, that they perhaps like to use some other formats or presentation. So now's the time to be able to, those things to the organisers. So, we really value that feedback, so we really like to hear from all of you, because really that can do it. So thank you for that.
I hope everyone heard that okay online. Is there anyone who would like to say anything, ask any questions or anything else? Rosie, do you have any comments? No?
I was also just going to remind you that to encourage you to apply for distinction. That information on what to do for that is available on Canvas. So encourage you, if you can, there's some really great prizes available. That way inclined, go for it.
Kapai. Okay, we'll tot up some marks. Once again, great hearing all your presentations and your thoughts, and good luck with the rest of your studies and careers. Kia ora.